join us on time, we can wait. We can start while waiting. And today is a planned webinar regarding the BMJ Rapid Recommendations and Strategies for Global Guidelines that are easier to adapt. Meaning we are going to discuss adaptability and implementability, and chaired by Per Olaf from Magic Foundation, and also Siri Seteleve and Steven Van de Witt from Magic team. So I'll pass the floor to you, Per.
Thank you. And just a second, I'll get everything started. Wonderful to have you all here. I'm Per Van Wick. I'm one of the founders and the CEO of Magic Evidence Ecosystem Foundation. We are very keen to find better solutions to adaptation and implementation of guidelines, and that's actually the scope of the webinar today. So fantastic that you have joined. And this hour is going to be run by Siri and Stein, my colleagues. And it's going to be a lot of group work and discussion. Siri will take you to the agenda in more detail. My role is just to talk a little bit about the background for what we're doing today and what we do in Magic in general. So I'll spend 5 minutes with an introduction and then hand it over to Siri. So I think we all agree, and I guess I'm speaking to the choir today, that healthcare professionals and their patients need clinical practice guidelines to make well-informed decisions at the point of care. This picture shows my favorite evidence-based medicine textbook, and you could see now that at the front page there's a tool, a shared decision-making tool, so that clinicians and patients actually can discuss treatment options. I think we also all agree that these guidelines have to be trustworthy and timely and accessible at the point of care. And this means that organizations developing guidelines, and I'm sure that many of you work in such organizations, have a demanding task because we have to apply the right standards. We have the Institute of Medicine standards. We have the GIN standards for trustworthy guidelines. But we also have methods for how to synthesize the evidence, as the Cochrane Handbook outlines. We have great methods for appraisal of best current evidence and for moving from evidence to recommendations. And increasingly, we realize that we also need technology to help, platforms, but also processes to make sure that those recommendations are produced and updated in a timely fashion. All this is now easier than before. Magic has developed one of these platforms. I'm going to talk a little bit about processes in terms of one of the projects we run called BMJ Rapid Recommendations. So many great advances in EBM makes this possible. But our realization, developing guidelines over more than a decade in Magic, is that we need to collaborate globally, both on evidence synthesis, and we actually also think we need to collaborate on guidelines. So that means international guidelines need to be produced and disseminated, and that means adaptation and then translation of guidelines becomes critical. Just a few more words about what we do in Magic. This is the picture of the Magic authoring and publication platform. So we use technology to make it easier to author and to publish and to dynamically update guidelines. So when we talk about adaptation of guidelines, we're now developing a new adaptation module in Magic app. And that comes on top of some very advanced technology already. So as many of you know, in such a platform, the guideline recommendations and the PICO questions and the evidence summaries are the entities, not the entire guideline in PDF. And this means we could adapt or update individual recommendations. This is quite an important concept for how to move forward on adaptation. This is an example of a great evidence summary and a recommendation being the entity. Here a COVID-19 guideline recommendation. The other part is versioning. So we have to be able to demonstrate or to show that this is a source guideline, this is an adapted guideline, or in the living guideline context, this is the most recent, and here are the previous versions. So technology should help in developing and publishing these trustworthy guidelines, and adaptation should also make use of technology. We realized in 2014, I think, that guidelines do not matter unless they actually have a true impact on patient care. So we came up with this evidence ecosystem framework. And in 2016, we launched the BMJ Rapid Recommendations, our lab to improve how we create and publish and update the guidelines. And this picture shows how we work in this evidence ecosystem. Triggered by new evidence, we should be able to move to trustworthy guideline recommendations disseminated worldwide in 90 days. We published about 22 guidelines now, and we're always trying to improve that upper part of this evidence ecosystem loop. And this is an example from COVID-19, where many of you know that there was a breakthrough for living evidence. We, together with many partners, show that we could move from new evidence that could change practice to living systematic reviews, network meta-analyses updated weekly, to several organizations publishing guidelines such as in Australia, NICE, and as shown in this BMJ publication, the World Health Organization, publishing updated guideline recommendations in a very timely fashion. But my point for today is that we're only halfway there, because who knows if these guidelines were translated, adapted, and implemented, meaning that we didn't complete the final steps of this evidence ecosystem. And that is really what we are talking about today. And this is a key focus for Magic in our research and innovation and product development, is how can we make it easier to adapt a guideline and to implement it. And then, of course, what implementation activities should happen following the publication. What we're talking about today is done within the so-called Enhancing the Evidence Ecosystem project, E3. And in E3, we're looking specifically how guidelines could be easier to adapt and implement. So the adaptability and the implementability of guidelines. That's the topic for discussion today. It's a project run from Norway. We are also testing active implementation in Norwegian hospitals, but we're talking again about the guidelines themselves today. We're using the BMJ Rapid Recommendations as examples, and then Siri will take you through how we work to translate, adapt, implement, evaluate the guidelines. Again, today we're going to talk about adaptability of guidelines. This is a funny word. So over to you, Siri.
Thank you, Per. You see my screen? Great. As Per mentioned, creating high-quality, evidence-based, trustworthy guidelines is a demanding task. And doing it in an international collaboration seems to be a wise approach. But how do you create international guidelines that will work well in vastly different contexts? The short answer, you probably can't. Guideline needs to be adapted and fitted to the specific context where they're intended to be used to be considered valuable by the end user. Yet the process of adapting guidelines is not without issues. Song et al. Have done fundamental and important work mapping out several challenges connected to adaptation of international guidelines, and found that adaptation challenges could be connected to different parts of the adaptation process. Now, today we'll focus on the challenges connected to the source guideline and the adaptation process itself. This does not mean that we don't recognize the importance of time and skill and resources that you need to actually do the adaptation, or that things like access to drugs or the size of your healthcare system could be huge implementation barriers for new research findings. But what we would really like to explore today, together with you, is how we could work towards enhancing the adaptability of the source guideline. We do believe that through considering adaptability and implementability early in a guidelines development, we might improve the next steps in the evidence ecosystem and thereby increasing the likelihood of a successful implementation in practice. So today, we'll present some of the challenges we found through one of our studies. We'll ask you to discuss them in breakout groups and perhaps adding some challenges. And then, as always in healthcare, we need to prioritize. We'll do so through a voting, and hopefully we'll also manage to discuss a bit about possible improvements. And do please feel free to use the chat during this meeting for questions and reflections you would like to share. And the E3 project that Per mentions used the BMJ Rapid Recommendations as the substrate. We know they're well-made international guidelines. They have nice infographics, and they're quite often accessed at the BMJ site. But how about their adaptability? Are they adapted and used in clinical practice? Quite a few have been reused in different contexts, but not without obstacles. We've done a survey among panel members from 14 different BMJ Rapid Recs, complemented now with some interviews with both the survey repliers and others with experience adapting different BMJ Rapid Recs. Most of the participants were experienced, at least in guideline development and clinical experience, and quite a few were also well-versed in guideline adaptation. Bear in mind here that we've included experience with both formal adaptation at the government level and hospital level. We have mainly gathered experience from Europe and Northern America, so that's a definitive limitation for us. The BMJ Rapid Recs our respondents had experience from is quite mixed though. This list consists of guidelines targeting primary healthcare as well as specialist healthcare. It's guidelines for medicine and for surgery. It includes guidelines for introducing new interventions, as well as guideline giving advice about the implementation of current practices. And the participants had several positive experiences with the BMJ Rapid Recs. They found them credible, rapid, easy to access, transparent search strategy, and the infographic is considered a benefit. But they also described several challenges. Not everyone had the same challenges, so we've tried to summarize them as this. The organization or group that published the international guideline might lack credibility with those adapting it, or there could be different perceptions of the organization's credibility. The challenge could be differences between the clinical scope of the international guideline and the need of the national local guideline group. For instance, a narrow scope for the international guideline, targeting just 1 or 2 clinical questions, while the healthcare personnel would need broader guidelines, targeting several questions related to patient care. Another challenge we found could be that guidelines take different perspectives. For instance, the patient perspective or the healthcare perspective, and they could use different evidence to decision frameworks. And that choice of perspective or framework could influence adaptability. Lack of transparency is a challenge if it's difficult to find details about the guidelines development process or the reasoning behind decisions taken by the International Guideline Panel. The recommended action could be too practice changing compared to usual clinical practice in various settings and contexts. So practice changing that it disrupts the current workflow. On this challenge, we perceive the action recommended to still be feasible, just not easily compatible with the current practices. The challenge might also be issues with feasibility and/or accessibility of the recommended clinical action, or it could be issues with acceptability or cultural appropriateness. And another challenge would be that the recommended action in the international guideline could be perceived as not sufficiently clear. It's unclear who really should do what, when, and how. Then an inconsistency between recommendations in the international guideline and other guidelines could be a challenge for adaptation, especially if this inconsistency isn't explained. It could also be a challenge for adaptation if the international guideline haven't considered what implementation efforts that will be required to really change practice. And last, there might be other challenges that we have not found in our material, but challenges you're familiar with. So, what challenges should international guideline developers address to help facilitate adaptation across various settings and contexts? Healthcare is depressingly often about prioritizing, and the same goes for guideline developers. So based on your experiences, which of these challenges do you consider most important to improve? Where should the guideline community focus its efforts? We'll send you to breakout groups shortly. You'll have about 10 minutes to discuss these challenges. Are they familiar to you? How frequent do they occur, and what is the most important one? And we might have missed the one you feel are a crucial challenge for adapting international guidelines. If so, this is your chance to get it on the list. Discuss with your group, and if you agree, present it in the discussion afterwards. We'll try to send you all a link in the different group rooms to a shared document with the challenges presented, so you'll have them while you're discussing. Just in case the technology decides to be unhelpful, it could be a good idea to take a screenshot of the slide as well. You'll have it here. Are we ready to go in the group rooms?
So my name is Stein van der Velde. Hi, everybody. I look forward to a discussion together with you. And I would love to hear back from the breakout groups. What's your feedback on the challenges that we summarized? So as Siri introduced, we would like to hear from you what you think is the most important factor. Are there any challenges that you think we might not have identified? Are there some aspects that are more frequent than others, or some factors that make it more complex for groups adapting international guidelines down the line? So I would like to hear back from your groups. I hope you had good discussions, and hope that you are willing to share some of your ideas. So feel free to raise your hand, and then I will appoint the persons to talk. Okay, please go ahead. I'm not sure how to pronounce your name, Abu Raoui. You are muted.
Sorry about that. I always do this. All right. So my name is Aberago. I'm a physio and interested in guideline development. I think one of the discussions we had in our group is that at what point do we start thinking about guideline adaptation? And then it leads to the discussion that should we be talking about guideline adaptation or recommendation adaptation? And then we talked about at what point do we, if we say recommendation is the thing to be adapted, at what point should the discussion happen? Do we start at a point where the international community or the international committee or the guideline developer have already given the recommendation at a very early stage where the recommendation is still being discussed because a series of steps? So as we pointed out, the loss of legal framework, there's loss of professional licensing, maybe drug licensing that differ from country to country, health technology accessibility and availability that makes one guideline recommendation in one setting to not to be applicable. So there is this need to start to talk about the adaptability earlier on in the recommendation, not when the recommendation has started. I mean, has already finished and will say, okay, it cannot be adapted to certain settings. So making recommendation, I mean, adaptation process or need for adaptation start earlier on. or maybe you can have a rough draft of the earlier stage of recommendation, made it available to people so that they know at what point the adaptation should begin. Because it's difficult to really adapt the final products. Yeah.
Thank you so much, Abraham, for sharing that perspective. So I understand that your point is to both consider the legal frameworks and the context of groups downstream by the international panel from the start, and also to ensure there is a good stakeholder consultation before finalizing the recommendation. Is that correct?
Yeah.
Thank you so much. So that was from group 10. Can I ask from another group, which other aspects have you discussed? Please raise your hand and I will appoint you. Okay, Harold, please go. Thank you.
Sure, thank you. I just we were discussing that an issue is that we keep on doing the same subjective activities to do any of this, and that a modeling framework that could accommodate all these tasks is not done. So decision modeling formally, where you can model all the concerns that or almost all the concerns of the challenges could be modeled, and we've known to do this for 30 years, but we keep on not doing it because it's perceived as being too complicated. And in the process, we've lost 30 years of effort. And so it's frustrating that we kill ourselves to get evidence synthesis, evidence in a very formal way, but then when it comes time to do the guidelines, it's all done subjectively.
Thank you, Harold. You were breaking up briefly. I captured the point where you said that there's a lot of focus on the evidence synthesis, but then the part where the guideline is being formulated, we would benefit from a type of framework, a model. Did I get it right?
That is correct.
And could you explain that model, what type of shape that could take? What would the model address?
So we have a paper on that question, but basically decision modeling can accommodate both the clinical problem, the evidence, the implementation issues, the cultural issues, that all can be represented in a formal framework with appropriate packaging that also makes the guideline as an output of the process rather than a guideline that then has to be adapted post hoc. So,
okay, very interesting. I would love to see that paper, Harold. I will get back to you. Thank you for sharing that. We are limited in time, so I will give one last group the chance to provide feedback, and then we continue to the next part. But those that are having good ideas, please write them in the chat so we capture those in the meantime. So one further person to share feedback, not from group 10 and not from group 3. No, okay, Jan, thank you so much.
Yes, since no one raising the hand, so we don't want to lose them. We were discussing a potential two solution, and one regarding from ICA regarding the variation of implementation or the variation of the recommendation from the existing clinical practice. So by which can be a challenge mentioned by Siri regarding implementation of the guideline. So the potential solution we were discussing is that can we for example, before publishing the recommendation, should everyone compare the new recommendation with existing recommendations or clinical practice, then justify the variation? This way probably can improve the implementability of the recommendation. This is one aspect we were discussing. Another one is that to improve implementation, instead of, for example, the acceptability, feasibility, etc., those factors should be considered during the decision-making process. But what if, instead of not, regardless of considering, if we can do a preliminary implementation test with a small group of target users to test the publishing recommendation, then adapt it a little bit or improve it regarding the implementation aspect. So this could be another way to improve implementation. So those are the two aspects we were discussing. Yeah.
Fantastic, great ideas. So if there are any other ideas, please write them down in the chat. I will now hand over again to Siri, because the next step in the process is that we will vote over the list of challenges. Everybody will get a chance to, in a more formal way, indicate what you think are the most important elements. So over to you, Siri. And you are muted, Siri. We can't hear you yet.
Thank you, Stein. That was several good suggestions. We're going to try to give you the possibility to vote now. You've had the opportunity to discuss with your colleagues. We've tried to have a short discussion in the group. I've also tried to add 2 more challenges while you were discussing. I'm not sure if I quite managed to capture your point. I apologize for that. But let's find out what you as a group consider the most important challenges. If you could use your phone, and scan this code. I'll also try to add in the chat. And this should get you to the poll unit. You'll be asked to put in your country and your experience. We won't record anything about your name or your email address. And then we'll see the voting live in a few moments. When you voted, just go out to the page. You won't come to any thank you or this is finished page. Okay, Stein, are you ready for the votes?
Oh, this is so exciting. Yes, I'm ready. So we have looked like we have 4 clear winners. We agreed on that. Okay, Siri, now we're seeing your lovely dog, but okay, so we all agree that feasibility and accessibility is one of the most important aspects to be considered more by the developers of international guidelines, except together with acceptability and cultural appropriateness. So this was about 50% of the participants who voted for that. To make it more transparent, your dog keeps popping up, Siri. The transparency of the process so that it's not requiring detective work by the groups that adapting the guideline to find information on the the decisions made and the process also rated high. To have more consideration of implementation efforts required downstream comes up high. And then we have kind of a quarter of you indicating that we could do more to explain inconsistency with other guidelines, to be more aware of the needs of groups downstream. So the international guideline might come up with a scope that is different from the scope needed downstream. To be clear about what is called the actionability and the decidability, what to do when, who should do it, exactly what should be done, so that the recommended action is as clear as possible, as precise as possible. The challenge of recommendations being too practice changing follows then. So it might contradict with well-established practice and leading to challenging situations, and then followed by guideline perspective and framework. So that relates to taking the patient perspective or the health system perspective, or simply using the 7 ETD framework in the guideline adaptation group, while the international group is using a different evidence to decision approach. All of that might lead to complications, and then followed by 3 other categories. So what we would like you to do now for the last part of this session is taking into account the aspects that are rated highest, that are prioritized. Are you having any kind of ideas what guideline developers could do better to consider feasibility, accessibility, acceptability? What ideas do you have? Please don't hesitate. We have only a couple of minutes left. If you have an idea, we love to hear. Jan.
Yeah, I'm not sure whether my opinion is correct, because for feasibility, accessibility, shouldn't this be context tailored? Like as an international guideline developers, should we consider specifically feasibility for specific context, or should we maintain an international level? So that's my uptake. If the role is adapter, for example, I'm adapting international guidelines. As an adapter, I think the most important aspect to consider would be feasibility, accessibility, acceptability for my context. So that's my only opinion for this now. Yeah.
It's a good question. If this is a role for the developer of the international guideline, if that group could do better, or if we should try and improve capacity for the adaptation groups to take account of this aspect. Okay, we have another idea. You, Maguire, please go ahead.
Hi. I think this sort of discussion comes back to one of the earlier points about what is it we're adapting? Is it the recommendation or the guideline? Guidelines are difficult to adapt. Individual recommendations are a lot easier. Sort of in my experience of working in adaptation and contextualization of NICE guidelines, around 80% of our recommendations don't change when they're contextualized. So that means that they're easily usable elsewhere, but it's the other 20% which cause all the work. So it's a matter of, I think, identifying that 80% of anyone's recommendations that don't need to change, no matter where they're being used.
That's an interesting point, Hugh, and that also matches with experience we have from work in Belgium. The same numbers, 80% actually didn't require adaptation. Do you have any idea about those 20% that requires adaptation? Would it be possible to kind of identify what kind of predicts adaptation? Okay. If there are any other
Sorry,
ideas
was
in
that
the
a question
meantime,
for me?
please raise your hand. Yes, you. If you have any ideas about that, I would love to hear. And please raise your hand if you have other ideas in the meantime.
Yeah, I think it'll come back to what was mentioned earlier about the sort of the context around health technology assessment recommendations, the status in terms of OECD development, knowledge about what's available in different countries, and also knowledge about the different healthcare systems. So going from something like the NHS in England to recommendations in India, where it's local, state, regional, and national level, make it a bit more difficult.
Yeah. Thank you, Hugh. Any other suggestions on how international guideline developers could improve? Siri, maybe we can summarize the suggestions that we received in the interviews. Maybe that generates a further idea, and if not, we will then go over to Per to finalize the presentation. So Siri, please bring up this last slide on possible improvements. So based on the interviews we had, we both asked to inform us about the challenges, but also to think with us about possible improvements. So what our participants brought up is that guideline developers at all levels could do better to ensure that the guideline is more practical and more clear on what to do, who should do it, and when. Also to inform, kind of taking a resource stratified approach. You might have some contexts where the intervention is accessible, but you might have others where it is not accessible. So what do you do depending on the resources you have? Would it be possible to come up with recommendations that are tailored to the resources you have at hand? Would it be useful if developers of international guidelines also come up with implementation considerations? Would that help groups downstream to adapt and implement the guidelines? And then we come over to these evidence to decision frameworks, where today we have the 4 ETD approach by grade, we have the 7 ETD approach, but we also have WHO having a separate evidence to decision framework, and there are more. So is this giving us a challenge that we are having different evidence to decision frameworks that might not always be compatible with each other? If so, what would be the best to use by international groups to make it easy downstream? And how could we help people reduce time to retrieve information that might be available in the guidelines, somewhere in the appendix, but that is essential to kind of verify the guideline development process? So these are suggestions we received. Is there any final burning thought or idea before I hand over to Per? Okay, Per, I think I'll hand over to you. Thank you so much.
Thank you, Stein and Siri, and thank you everyone for joining. It's been a pleasure to listen to the great points made. I think this is a challenging area under development. We're now including considerations about adaptability and implementability in the ongoing BMJ Rapid Recommendations, and it's actually quite hard to write something from an international guideline perspective that is meaningful. So to your point, Yang, we can't talk about everything relevant for every context. So it has to be building on the clinical expertise, so the experts here from all continents, and to say something that's useful for you in the UK or another one of you in Africa, wherever you are, to make it easier to adapt. So it's very welcome with all the feedback you gave. I think there were some clear priorities that came up that will help us move this forward. And I just wish you a wonderful morning or afternoon or evening, and thanks for joining.
Great. Thanks to everyone. Bye. Have a good one.
Bye-bye.